Well, we get to spend the next 50 minutes talking about refractive surgery. And I think Brooke's new. So we get Professor Plum, AKA Dr. Swan, Dr. Messer as Miss Peacock, myself as Miss Scarlet, Dr. Witt as Mr. Green. His socks are green. And Dr. Dede as Miss White. A little bit about Miss Scarlet, just in case you guys are not familiar with her. She often, I'm gonna struggle. She consistently is associated with the color red. So, I mean, I nailed that. I got that. In the 1985 film, it's revealed that Miss Scarlet is being blackmailed by Professor Plum.
No way.
True. She is often portrayed as intelligent and manipulative, using her charm to her advantage.
Check.
And in different versions of Clue, Miss Scarlet's occupation varies. She's been depicted as a freelance spy, a socialite, an actress, a gossip columnist, and today as a refractive surgery know-it-all.
Oh, that's better. Thank you. See, and you said that I was mean, but I just texted them to do that for you. Wasn't that nice?
It was nice. Thank you. Refractive surgery, everybody knows, surgery that changes the way the eye focuses light on the retina. For our patients, it's known as a way to get them out of their glasses or contacts. We are not going to talk through every refractive surgery option, but here's kind of what we'll talk through today. The corneal procedures we'll go through are our most common LASIK, PRK, and less known LRI. Lens-based procedures, phakic IOLs, RLEs, and then we'll talk through some cases as well. Laser vision correction reshapes the cornea using computer-controlled laser, again, LASIK and PRK, which everybody's super familiar with. That's going to be most ideal for mild to moderate refractive error. We can treat higher amounts, as you see on the bottom, but the sweet spot, I would say, is probably like the -3 to like -6. They need to have good corneal thickness, good corneal symmetry, and overall just generally healthy corneas. The parameters are, the laser can treat up to 12 diopters of myopia, 6 diopters of hyperopia and astigmatism. It's pretty rare that we go that high. I would say pushing the limits, we'd maybe do like 9 diopters of myopia if they have good thick corneas. And then hyperopia, probably more likely around like a +3 spherical equivalent. And astigmatism, like 4, 4.5, 5, pushing the limit. Anybody disagree with that up here?
Yes.
Mr. Green was shaking his head at your
Oh
minus
my gosh.
9 seems so high.
It's high, but I mean.
That's what ICLs are for.
ICLs are a nice option too.
Yeah.
We'll get into that.
I love my ICLs.
Do you have ICLs?
I do have ICLs in both eyes. So.
What was your previous prescription? -9?
8.
Yeah.
I would say we start consistently talking about ICLs around -5. I just think about the induced, and you've talked about your higher minus, right? Refractive surgery, post aberrations, and how, it maybe impacts it in the future on cataract decisions and things. And so I'd rather not touch the cornea, especially if we have, a fairly young patient, mid-20s. I would definitely encourage that ICL, because it's a big change to the way that light goes through the cornea, and I'd like to keep it as pristine as possible, and so I'm a big fan of ICLs.
Alicia, did you have enough corneal thickness for LASIK?
It was going to bring me really close, and I wasn't comfortable with it, with how much it would have changed my corneas, like Brooke mentioned there. So I looked into ICL and really liked that option. I wanted to keep my options, fully open as much as possible down the road. So ICL's been great. I've had them for about 1.5 years.
Yeah. Okay. When patients come in for refractive evaluation, we take them through quite a bit of preoperative testing, and we do a full pre-op when they come in, so we do dilate their eyes. So it's nice if they've been given a little heads up on that ahead of time. So we get topography and tomography measurements, we use a pentacam in Billings. And again, looking for corneal symmetry, corneal thickness, any weak spots or anterior posterior float, which can be early indications of keratoconus. Anterior chamber depth is important for patients who we may be considering ICL on. And then the Topo Vario is the machine that kind of communicates with the laser. So again, tons of information that comes from that. But most of it is going to be like the iris registration. And then also, if we're doing a topo guided treatment, we use the data points from that machine that communicate with the laser. Obviously, we do a wet and dry refraction and looking for just stability, accommodative spasms. A ton of that is going to come from you guys as well. So we have that to check back on. Good ocular health, so front to back of the eye, we just want to make sure everything's healthy. Dry eye is so prominent in Montana, and so I have that conversation with just about every patient, even preoperatively, and even if they don't have symptoms or signs, just letting them know that most refractive surgery is going to make their dryness worse. We already live in a dry state, so we kind of have that working against us, and just kind of talk about the importance of treating it postoperatively, and that it doesn't work unless you actually do it. Additional testing and information that comes from you guys that's nice for us to have is just like a good history. So what their goals are, if they have any history of amblyopia, if they have done monovision, things like that. And we talked about that a little bit in the last talk. So there's different treatment planning options, and conventional is the most common one that you would see for your patients that had LASIK like 20 years ago. So very basic treatment planning where it's just correcting the patient's lower order aberrations, sphere and sill, but it does induce quite a bit of higher order aberrations. And so those are the patients that come in complaining about, they say I had LASIK 20 years ago and, I have pretty poor nighttime vision quality. Wavefront optimized we use currently. This is one of our current treatment planning options. And the nice thing about it is that it reduces the induction of new higher order aberrations. So we still utilize the manifest refraction that we get, and then it's a population average of aberrometry data. The difference between this and the conventional LASIK treatments are that the treatment zone is wider and there is kind of a prolate shape to the treatment. So it maintains the patient maintains their kind of natural corneal curvature compared to what they would have in conventional LASIK.
When did it switch? Like when did Wavefront Optimized start being mainstream?
So, both Wavefront guided and Wavefront optimized. So the Vizx laser from Johnson & Johnson and the Exmer laser from Alcon. In the mid 2000s is when that came available.
2004, I think,
Yep.
for Wavefront.
2004? Okay, so anybody pre-2004 definitely had conventional LASIK. Okay, just...
As the elder spokesman at our panel, we'll rely on Travis for the correct answer to that.
Good point. Happy belated birthday, by the way, Travis.
Alicia wasn't born yet.
Alicia said she thinks she was in elementary school then.
I was like, I was definitely born, but elementary school probably.
And
Move it along. Let's go.
Moving on. We did touch on topo-guided treatment a little bit in the last talk as well. So that is meant to actually reduce existing higher order aberrations. So the sweet spot is a little bit more for an irregular cornea for patients who maybe are symptomatic, just as their cornea is from some asymmetry or irregularity. And so the goal is to sort of normalize the cornea a little bit more and actually lower the higher order aberrations compared to pre-op measurements. So we use the Alcon EX500 platform, and so these are the two treatment planning options that we have with that laser. Wavefront guided, as Russell mentioned, is a Vizx treatment platform. So the way we kind of go about choosing what treatment plan we're going to make is based on, again, the pre-op higher order aberrations. Are they low? Are they high? Does the patient get a good endpoint refraction? So do they see really well in their glasses or contacts? And again, just kind of what their quality of vision is. And does that maybe poorer quality match the corneal topography that might be a little bit irregular? And we do a decent amount of both of those, I would say, yeah. LASIK complications, as we all know, are pretty rare, but they're not non-existent. And so, again, patients coming in for pre-op or for refractive evals, we talk through these. Infection is less than a 1% risk, and risk factors include blepharitis, hygiene, non-compliance with drops, and then, maybe dirty areas after having the procedure. PISC is less common, and I don't specifically go into that complication with patients, but we're going to talk about it later in the presentation. And so it's rare. It can be difficult to identify. I've seen it one time. I've heard about it a lot, but I've seen it one time. And it's an accumulation of fluid at the flap interface, generally from the pressure being high. It can be tricky though, because the pressure doesn't always read high. That fluid interface can throw the pressure reading off a little bit, so sometimes the pressure will read artificially low. DLK, most people are familiar with. It is non-infectious. It's inflammation at the flap interface, and usually you'll see that pretty early on after LASIK within the first few days. If the patient had LASIK years ago but had recent trauma, that can sometimes reactivate that a little bit too, and that's going to be treated with pretty heavy steroids. Flap stria is not uncommon. You don't need to necessarily worry about it unless it's visually significant. So if they're kind of big folds in the flap and they're central and the patient has poor quality vision because of it, then a flap lift would be in order. Flap dislocation kind of goes along with the flap stria, but rare, although can happen. And again, most of those would be happening in the early days after surgery outside of trauma. And ectasia, of course, is rare, but I do talk to patients about that. Even if they have normal corneas, I think it's worth a mention just so they know what it is and they've heard it before. And same kind of with PRK, some of those overlap. Corneal haze is going to be a little higher risk with PRK than it would be with LASIK. We use mitomycin with all of our PRK patients just to help reduce that risk, and it's going to be a bit higher in the patients where we do high ablations. Dr. Swan would be the good example of that, although he turned out really well.
No haze here.
Infection is also low with PRK, but important to kind of watch and monitor and stress the importance of good hygiene, especially while they have the bandage lens in. Ectasia is even lower in PRK than with LASIK. And then delayed epithelial closure. If you're seeing a patient kind of stalled in their healing where they get to like 90% closed and then just aren't budging, and you're maybe 6 or 7 days after the procedure, then probably something needs to change, like the BCL needs to come off, maybe put an amniotic membrane on, suspect viral, so you could start Valtrex, may need to stop the steroids. So lots of different ways to go about it, but something probably should change at that point. And then again, dry eye, just stressing that all the time with every patient when they're having eye surgery.
What is your dosage of Valtrex if you see this? Do you do the...
I would do full dose.
Full dose.
1 gram TID.
Yeah.
Yeah.
That's one thing that I see a lot is, for some reason, people start more of the, 500 milligrams 3 times a day. And patients tolerate Valtrex extremely well. Just 1,000 milligrams 3 times a day. Make sure that you cover all sorts of the, herpetic aspect of it. I always wonder why people go half dose. And so when they're thinking, simplex versus zoster, just do the full zoster dose, especially central cornea, more concerned about that potential for the trigeminal nerve influence or interaction there.
Yeah. Yeah, I think the downsides of going full dose are pretty slim.
Pretty minimal.
Pretty minimal.
Yep.
Yeah. Limbo relaxing incisions, I don't know, these are still done fairly commonly in our practice. I don't know outside of our practice how often they're done, but we use them in the setting of, most often in the setting of post-cataract patients who might need a little fine tune. And somebody with a plus 50, minus 1 prescription is gonna be a really good option for them. And so if a patient, if we're seeing, I'm getting a little off topic because I'm talking about cataract surgery here, but if we're seeing a patient for cataract surgery interested in an advanced lens who has already had LASIK and may not be a good candidate for a fine-tune, LASIK fine-tune, we talk to them about that on the front end, and I do tell them, hey, we may have some options to fine-tune things after, but you have fewer options than somebody who may have never had LASIK or a healthy cornea. So they're just little arc-shaped incisions made at the limbus meant to reduce the corneal curvature in the steep axis. Incisions are made using either a diamond blade or a femtosecond laser, and again, a nice option for patients post-cataract with mild mixed astigmatism. Russell, do you want to talk about any of the details with the diamond blade versus femtosecond?
Yeah, so typically for corneal relaxing incisions, there's kind of two ways to think about it. There's true LRIs, limbal relaxing incisions, which means they're made at the limbus or within about 0.5 millimeters of the limbus. What's nice about those is they're probably the most forgiving corneal incision that we have, meaning because they're farther away from the central visual axis, you're less prone to develop skew or otherwise. With a traditional LRI, limbal relaxing incision, that's that far to the periphery, there's actually no femtosecond lasers that will do a treatment that far out at the periphery. So classically, a traditional LRI or limbal relaxing incision is done with a diamond step blade, where we will look at their corneal topography map, we'll see their peripheral corneal thickness that they have. We'll adjust to about 95% depth to do the treatment, and then we'll mark out where we're going to do it, whether it's a 20-degree arc, 30-degree arc, 40-degree arc. Usually they're paired, but they can just be singular and do that. For traditional femtosecond associated, what we'd call arcuate keratotomy or AKs, those are usually at the 8 or 9 millimeter optical zone. Some new femtos can go out to the 9 millimeter optical zone. And most commonly, those are done at the time of cataract surgery with a femtosecond laser. You could still do it after cataract surgery as well. But so for most of our patients, if we're doing a limbal relaxing incision, we're typically doing it after. They're a low astigmatic patient that maybe, with cataract surgery, it's not calling for a toric lens, but they have 0.75 diopters of corneal sill. And we might talk to them on the front end. You might need a little fine tune. And if they're spherically equivalent or, at zero spherical equivalence, but have 0.75 to 1.5 diopters of astigmatism, this can be a really nice option with a really, pretty easy healing process. And if it gets it but doesn't get it all the way, we can still do LASIK or PRK even after someone's had an LRI, which is also nice.
I don't have slides for this patient, but we had a lady that came in to her patient, to her husband's cataract eval with him. And she was kind of sitting back in the corner and said, "Hey, can I ask a question? I had cataract surgery a few years back and I still have a little bit of blurry vision. Is there anything I can do about it?" And I said, "Well, I don't know, but we can bring you back in on another day and get some measurements and talk about if there'd be any options." So like a month later, she's on my schedule for a refractive eval, and she's, probably 70, and comes in, and I'm looking at her chart before I walk in the room, and she's 20/20 minus, and has had LASIK previously, and I'm like, what is this lady doing here? Who sent her in? And then I realized it was me. So I went in and I started talking to her about how there's not really a surgery that's a good option for her before I had even done any testing, because she's 20/20 minus, and was already kind of talking her out of it. And then I refracted her, and she refracts to a solid 20/15, and she's +0.5, -1. And so then I sort of backtracked and said, well, maybe we could do an LRI, and explain to her what that was. And she was going to think about it for a couple days. She did call back and schedule. We haven't done her LRIs yet, but that's like a prime candidate for that. Can we make the main slide? Thank you. So again, just kind of quickly to talk over the complications of LRI. Any procedure carries a small risk of infection, low with LRIs, over/under correction. Corneal perforation, I don't have a percentage on that. I would assume really rare, Russell.
Yeah, super rare. And it's usually if when LRIs are done without having a corneal thickness map, and they're just pre-planned at 600 microns or 650 microns without somebody either doing ultrasound pachymetry or optical pachymetry to know that, in fact, this is a patient that has a thin cornea. So very, very unusual if you're actually mapping the corneal thickness.
And then still dryness as a topic of discussion. All right, first case. Oh, man. So this is a 72-year-old. Referred for cataract evaluation. He had LASIK 20-some years prior. The referral had stated that he had a recent episode of anterior uveitis, but that it had cleared a month prior. Still had some chronic KPs. His wife was with and said he does have some memory issues. His best corrected vision was 20/25 right eye, 20/40 left, uncorrected 20/25 right, and 20/100 left. His pressure in his left eye was pretty high when he came in, and he did have a little bit of cell in the AC when I saw him, and so also worth noting the cup to disc asymmetry for him. The plan for him was to try to clear that little bit of cell that was left and then manage the pressure. So we restarted him on pred with a 4-3-2-1 taper, and then began Combigan and told him we wanted to see him back in a week to recheck the pressure. So he comes back in a week. Pressure's a little better. His uncorrected vision is worse in the left eye. Because he had improved with, the IOP had improved, we decided to continue on with the steroid taper so that we didn't get a reflare, and then keep him on the Combigan. 3 weeks later, he came back again, and pressure was up a little bit again. Vision in the left eye was even worse. The chamber was quiet, but his cornea had this really kind of edematous, hazy appearance, and we didn't get corneal scans that day, but that was the reason for his vision drop. We suspected viral keratitis and started him on a full dose of Valtrex, so 1 gram 3 times a day. And then he or his wife had kind of admitted that he hadn't been using the Combigan. And there's a little bit of a pattern with him as we go through the treatment that, like each time he'd come in, he'd say, yeah, I think I've been using it, or which one is that again? So probably not super compliant. We saw him a bunch over the next several months because we were trying to, 1, clear the cornea, and 2, make sure that the eye remained quiet enough for him to proceed with cataract surgery, because that was the reason he was sent in. And his cornea did kind of fluctuate up and down a little bit with the haziness, but it never got super clear. We eventually, because the AC was quiet and the eye was pretty stable, we eventually did cataract surgery with a lot of discussion preoperatively that his eye was just kind of behaving funny, and we still wanted him to be on the antiviral, but put him back at the full dose when he had his cataract surgery. So we did cataract surgery. He got referred back about 2 months later for persistent corneal edema. He was on, when he got referred back, he was on Cosopt twice a day, Valtrex, still at just once a day at this point, and then Durezol 4 times a day. He was now hand motion in his left eye, and pressure was 20. We did get a scan that day, and so the top scan is his initial evaluation. That's the pentacam on his left eye from his initial evaluation. The bottom scan is this day when we were seeing him back 2 months after cataract surgery. So you can see the difference in corneal thickness. He went from a PAC of 509 to almost 600 at that visit. He had quite a bit of conjunction, still had that stromal interface haze. He had, on high magnification, really thin slit beam, you could see a little pocket of fluid at the flap interface. And so on this visit, he was diagnosed with PISC from the pressure being high for a long period of time. And what would you do for this guy? Here's our options. I think the poll is on the next slide. But increase the Durezol every 2 hours, remain on Cosopt, remain on Valtrex, add latanoprost. Decrease the Durezol, add Miro, stop Cosopt, remain on Valtrex. Discontinue Durezol, continue Cosopt, start Vyzulta, remain on Valtrex. That's supposed to say remain on Valtrex. And, or send it to Dr. Dede, which is what I should have done, but I didn't.
Could you have sent it to Dr. Dede at week 3?
What?
Could you have just
Probably.
sent it to Dr. Dede at week 3?
I don't know if I was there. I actually
Oh.
haven't seen this patient personally. I'm not sure if I was there yet or not, but
So I'm going to have Dr. Dede kind of talk through her thoughts on this and what do you think you would do? And I think we can do that while the poll is up.
well, I personally haven't seen PISC. Heard about it, haven't seen it, so I'd be interested to see this patient underneath the slit lamp. But I think because the pressure, well, I'm actually interested what the back of the eye looks like too.
Can't see it.
Oh, not at all.
No.
Okay.
Not well.
Okay.
Do we know the source of his uveitis?
Yeah.
Because, you know, is the
Viral.
pressure,
We didn't do like a systemic workup on him.
because, you know, it's hard to decide to leave him on the steroid if it's steroid-induced pressure, or does he need the steroid because it's a trabeculitis? So that's where, is this like a uveitic, you know, glaucoma, or is it?
Yeah. He didn't have, he never had AC inflammation again after that initial visit.
After he cleared?
Yeah. So, yeah.
Personally, I'd probably lean towards stopping the steroid. Had he ever been off the steroid? Okay.
Yep.
I would stop it. I would hammer it hard with the Vyzulta, keep him going on the Valtrex, keep going on the Cosopt, and see how he responded there.
And that's why the poll says send it to Dr. Didi.
That's right.
It was up there. You were the winner.
If I go back to this slide, that is his actual OCT, and I don't know if you can see it on the slides up here, but you can see like the little interface pocket of fluid on the OCT. We did what Dr. Didi said, which was try to get him off of the steroids, assuming that that was part of the pressure problem, and then put him on a bunch of pressure-lowering medications.
Could you see the fluid interface slit under the slit lamp now?
Currently or at that visit?
Well, you could see it on the OCT,
Yeah.
so could you also see it?
I
at
could
the
see it
slit?
on the slit lamp. We got
Yeah.
the OCT after because I could see it.
Yeah, so when you see that, you kind of throw pressures out the window because you just assume that they're higher than what they're reading because that fluid cushion.
Right,
So,
right.
you know, you just kind of assume pressure is higher than, say, the 29 or whatever.
Yeah.
It is. So it's probably
Yeah, 'cause-
closer to like 60 or something.
Yeah, he didn't read super high at that visit, but I think we tried to do like an off-axis reading, and it was higher. I don't have it on here as to what it was, but so just a little bit more about PISC. Again, as I mentioned earlier, characterized by interface haze and fluid accumulation, often linked to steroid-induced ocular hypertension. It's a late onset complication, can be weeks, can be months or years after having LASIK, and increased IOP is what causes that fluid to leak into the interface. Usually it's a patient with a long history of steroid use, and that helps in kind of the diagnosis.
Can I just mention one thing?
Yep.
You know, these are so tricky to see, and it's so rare. But I think as a general thing, you know, if you see corneal edema, we're thinking, is this, you know, common things being common, is this endothelial dysfunction from Fuchs or pseudobolus keratopathy, or is this viral? And if you have a swollen cornea that is persistently non-responsive to that, or is no longer responsive to it, that's where we got to kind of think outside the box. And actually pretty amazing for you actually to visualize this. It's really hard to see, but it is one of those things where an anterior segment OCT, the pentacam, you know, corneal thickness of 600 in someone who's had a big refractive procedure as well, like probably means he'd be like 700 if he hadn't had a corneal ablation. So again, persistent edema, non-responsive to our classic steroid treatment, which most of those other things would respond to in antivirals, is a good cue that this needs a little further attention.
I think I'd also add that outside of the corneal edema, I've seen a couple of these where they present with more of a DLK appearance, where you see, where if you've seen enough DLK, it's pretty easy to flag, and your first response is hit him with steroid, right? And then it just gets worse. Like that's your immediate cue at that point, regardless of what pressure shows, because again, to Brooke's point, the pressure is kind of often falsely measured, where it sounds backwards. You're looking at this cornea, it looks inflamed, it has this keratitis component to it. Obviously, it has a potential to have edema more so like this patient, but I've seen him with minimal edema and just looking like this diffuse keratitis, and it feels wrong to pull him off a steroid. It's a risky move. It feels like where you're like thinking about it for the next 3 days. But to Russell's point, I think for these cases, as rare as they are, when they don't make sense, like the best step is get more testing, get an OCT. When there's edema, it's hard to evaluate the cornea anyway, let alone try and see, interface fluid at that level.
I was curious though, you mentioned right away that the nerves had some asymmetry. Was the patient diagnosed with glaucoma?
Didn't have a glaucoma diagnosis coming in, I don't think. And through the course of it, his nerve is hard to see at this point. And so So that's kind of another concern. Like once the cornea is clear, what's the nerve going to look like? We saw him a bunch of times after that, and he just didn't respond to the pressure lowering measures. And so, so whether it was his cornea didn't respond or he wasn't actually using the medication is hard to say. That adds to the complexity of it. But we ended up doing a MIGS procedure on him to try to get the pressure down a little bit. He's probably like a month after that MIGS procedure now, and his cornea does look better. The interface fluid is gone. His cornea is still not perfectly clear, and he's just a tough case. So this one will be ongoing, and maybe I can report back next year, but I included it because it was PISC, and I'd never seen it before. All right, next case. This is pretty straightforward, but I think a good reminder and message here. 56-year-old emergent visit for slipped flap. She had had LASIK 1 day prior at an outside clinic and had called. We got a call from the patient's routine eye doctor while the patient was at her 1 day post-op saying that she had a slipped flap and was wondering if we had a surgeon here to reposition it, and luckily we did. I didn't see her, Dr. Didi saw her, but when she came in, she reported pain and was using the drops as instructed, doesn't remember rubbing her eye or bumping it or anything like that. She was 20/30 in the right eye, 2200 in the left, normal pressures, and the picture is her actual eye, correct? So she was dislocated in the left eye, and she was maybe slightly dislocated in the right eye. She had a little bit of stria there. So luckily, Dr. Swan to the rescue was able to reposition both flaps the same day. We kept her on the Pred-Moxie combo, and then had her back the next day, and she was doing really well. Sorry, this is the 1 month. But we did see her back the next day, I think, right?
Yeah, I followed her pretty close.
Yeah.
She was doing much better the next day, and then I would say a week later, much better, and then 1 month, she was very happy.
Perfect. So 1 month, 20/20 in both eyes, a little bit of flap stria in the left eye on the nasal edge, but nothing that was visually significant. And flap dislocations are rare. Usually they're going to happen early after surgery. And I just put this on here because LASIK complications in general are rare, but you just want to make sure you have a good plan for when things don't go well. And so a responsive surgeon and a good team to have your back if things didn't go exactly according to plan.
The other thing that I would just mention about this patient, and I think it goes into like having a comprehensive refractive outlook for a patient. So this is a 57-year-old, I think we said 56, sorry.
Yeah.
56-year-old lady who had hyperopic PRK at 56. And just my personal opinion, hyperopic LASIK is fine. We occasionally do it. But hyperopic LASIK on a patient who's in their mid-50s and maybe starting to experience some lenticular change and going to have regression, I don't feel like was probably the best long-term option for this patient. And a lot of times, again, we see these patients, and rarely and occasionally we will do hyperopic LASIK, but more commonly we're talking to them, hey, I would either do a refractive lens exchange or do nothing and just stay in your current glasses or contacts. But hyperopic LASIK at 56 is probably not the best investment of your dollars for getting you the best visual outcome for you for the long term. So just another aside or point about, again, as we're thinking about these patients from a very comprehensive approach of what refractive options do we have, and not just LASIK only, but LASIK and ICL and refractive lens exchange and all these other options, trying to think what would be the best option for this type of patient.
Yeah, that's a good point.
Let's say that, this happens and they can't be repositioned like within 1 day. What would we do as an optometrist? What would you want us to do? Do we put, how do we do anything? Do we put a BCL on to make sure it doesn't go further? Do you tell the patient just to keep their eyes closed? Like how would we manage this if, let's say, they can't see a surgeon for 4 or 5 days?
Well,
hopefully it's not that long, but what if it is a couple days?
Yeah, no, correct.
What would you tell us to do?
Yeah, I mean, the biggest thing is just making sure they have great antibiotic coverage. So usually we'd keep their antibiotic and steroid both at 4 times a day. And again, the sooner, the better. And so this is one where, like, say I'm backpacking in the wilderness and I can't be seeing this patient. Like, this is a patient who I would ask our team to call the other LASIK surgeons that are in the state to see if they could reposition them. And I think, again, ideally 24 to 48 hours is ideal. The reality is that what happens with these patients when they shift, they have the stromal involvement, which creates the folds and decreases their visual acuity. But then what quickly happens, even over the course of the first 6 to 12 hours, is they'll start to get epithelial remodeling. So they'll have, a stromal bump, and in the stromal valley adjacent to it, the epithelium will thicken to fill in the valley, and it'll thin over the top of the stromal ridge. And so then the longer that happens, the harder it is to get that flap to fully lay flat. And sometimes we even have to debride all of the epithelium in order to get the stroma to be able to stretch flat. So again, sooner the better, ideally 24 to 48 hours. If this happens on the weekend, it's, call and try to find somebody, and hopefully you can find somebody that's willing to see them as quick as possible. Again, they can wait a little bit longer. Their risk of infection is quite actually low as long as they're on antibiotic coverage. It's just it's just a little easier to fix procedurally. So.
Thank you.
I think I'd also add it, obviously depends on the severity level of it. For patients that don't have like an actually dislodged flap, that have more, you can see microstriae, but there's no gutter, there's no furrowed edge there. Especially patients that maybe they're off axis, they're 20/20 minus day one, which is not uncommon. To your point, like, yes, typically they're easier for the surgeon to correct the sooner you do it. But I've also had patients where I see kind of off axis microstriae, they're 20/20 minus, they're doing pretty well, they have no pain. And I tell them, like, hey, we see some mild imperfections here. We're going to monitor this closely. There's a potential that in the next 1 to 3 weeks, we decide it's best from a long-term vision standpoint to go in and do a lift flap and kind of smooth this out. And that with that, there may be epithelial debridement. There may be a little bit longer of a recovery process, but there's also a potential that you see them back at week 1 and they're 20/20 plus, and these mild imperfections have minimal to no impact on their vision.
Yeah, that's a great point. Outside the visual axis, microstriae, usually they'll do fantastic, to your point.
At what point do you give the optometrist the thumbs up to attempt to reposition that flap?
I wouldn't. I don't think it's helpful, because the biggest risk actually is, when you go to lift that flap, the critical thing is debriding all the epithelium that's in the gutter, debriding all the epithelium that may have already grown underneath the flap. And so I just think this is something that you want a surgical microscope to be able to do. So, because the risk of epithelial ingrowth, if you're not debriding that epithelium fully from the gutter, but also from underneath the flap that's already there, the risk of epithelial ingrowth is very high.
All right. We covered that fully. So moving away from the corneal refractive surgery options to lens implants, RLEs, ICLs, piggyback IOLs, going to be a little more ideal for high correction and or thin corneas. Phakic IOLs can be placed posteriorly or anteriorly. We most commonly place them posteriorly. And we now have this fenestrated, this isn't super new, probably in the last, 3 years or so, fenestrated ICL that eliminates the need for a PI, which isn't the end of the world to get a PI, but it's a nice extra, it's one less step that the patient has to go through, and those carry some risk as well. So that was a nice advancement in the ICL. They are approved for treating myopia from a -3 to a -16 and reducing myopia up to -20. So again, this conversation can be had in a wide range of patients, low correction all the way up to very high correction. And they do have a toric version that corrects anywhere from a diopter to 4 diopters of astigmatism. It is not approved for hyperopia, and the anterior chamber depth has to be greater than 3 millimeters. They also need a normal, healthy endothelium. And then this is not FDA approved yet, but in the works, which is EDOF ICL. And I would say, the sweet spot for that, when it is approved, will probably be kind of the early presbyopes, age range 45 to 60, who maybe would be at a high risk of retinal complications if they did an RLE. So we haven't implanted it yet, not approved yet in the US, but I don't know what the timeline looks like for that, but it may be on the horizon. ICL complications, high IOP from the vault being too high, inflammation, infection, all those not common things, but things that we talk about with every surgery. Early cataract formation if the vault is too low, and then endothelial cell loss. And so we do ask these patients to see their eye doctor once a year. Not a bad idea to have an endothelial cell count done every once in a while. If they do have a little leftover prescription, we can fine-tune that typically with a LASIK touch-up if they have healthy corneas, and then lens rotation or misalignment. And again, just kind of stressing the importance for these patients that because they don't need glasses doesn't mean their eyes don't need evaluated and care every year. Piggyback lens is going to be most commonly used in a patient that has anisometropia. So like a patient that maybe had cataract surgery years ago from a retinal complication and now coming in very myopic, but coming in for cataract surgery in the other eye. Complications, intralenticular opacification, so cells growing between the IOLs, uveitic glaucoma hyphema syndrome, and lens dislocation. And then refractive lens exchange. Russell talked through a lot of the lens options in his cataract talk, so we won't spend a ton of time on that. But a nice option, I mean, the patient that we just talked about, the LASIK patient, is sort of a prime example of what the refractive lens exchange would be a really nice option for. So they're hyperopic, they're presbyopic, want to get out of glasses, and so, nice option for those patients without having to laser their cornea. We'll kind of skip this one because Russell talked through all of these in pretty good detail. And move on to our next case. So this is a 59-year-old cataract evaluation. She had this was, again, sort of the prime case for this, but she had retina repair with a buckle years prior and then had cataract surgery to follow. Her uncorrected vision was count fingers in the right eye and 2200 in the left, 20/30 corrected in the right eye and 20/25 in the left. And she was still quite myopic even after having cataract surgery. They left her myopic because didn't want to induce too much anisometropia when they did her cataract surgery. So she came in wanting to be less dependent on glasses. She didn't care that much if she had total independence, but wanted to reduce her nearsightedness, but she was very price sensitive. I think, Travis, this one was going to go to you, but we'll do a poll here on this one in a second. Were you paying attention?
She was distracting me.
Okay, well, this will be fun then.
Oh, boy.
So treatment plan for her, plan a standard lens in her left eye with a myopic target and reduce the myopia in her right eye with LASIK. Plan a standard lens in her left eye with plano target and LASIK in the right eye with a distance target. C, plan a standard lens in the left eye with a plano target and lens exchange. What are you doing? Stop.
Oh, I was trying to go back the other way to see.
And you wanted to see her.
How old is this patient?
She was 59. That's what I said. Plan a standard lens in the left eye with a plano target, lens exchange in the right eye for a distance lens, or D, standard lens in the left eye with plano target and piggyback lens in the right eye with a plano
Travis,
target.
her spherical equivalent in her right eye, which is pseudophakic, is -8, and she's -5 spherical equivalent in her left eye.
And her left eye.
Since Mrs. White was
cataract surgery
distracting
a
you.
long time ago.
Does she take her glasses off to read?
This feels very
No.
reminiscent of optometry school and not paying attention when somebody calls on you.
I only have 6 minutes, so make it quick.
Sorry.
What would you do?
So there's three diopters of aniso.
Yeah. And
Mine's
her desire is to be less dependent on glasses.
I believe piggybacks only go to about 3 diopters, do they not? Does it go? I'm going to guess D.
Yeah, good job. So
It's a good guess.
she was very price conscious, and she had very realistic expectations, but did have some desire to not be so nearsighted when she was done with all of it. And so you can bill a piggyback lens to medical insurance with the diagnosis code of anisometropia. So we did plan a distance target in her left eye just with a monofocal lens, and then a piggyback lens, which is placed in the sulcus in the right eye. We did those a day apart, I believe, because it was being billed to medical insurance. And can we make the main slide bigger again? Thank you. Post-op day 1, she was seeing really well. 20/20 in her right eye, so that's the eye with the piggyback lens. 20/15 in the left eye with a monofocal lens. Happy and doing well. She knew she was going to have to wear readers. At the 1-month post-op, she had shifted a little bit, slid back a little bit, and had a little bit of mixed astigmatism. But overall, really happy and achieved her goal without with minimal cost to her. Anything to add on that?
And to Travis's point, there's limitations of how far we can go down with a lens here. So when we're talking about anisometropia, all those options are great. We can do LASIK, we can do a piggyback lens. Within the piggyback lens space, we can do a standard basic monofocal 3-piece lens, which would be fully covered by insurance, but might not get everybody. The alternative is we can off-label put an ICL or an implantable Collamer lens, and then you have a lot larger correction that you can do in that situation. It's just the patient has to pay out of pocket for the lens. Or you can even do a light adjustable lens, an LAL plus lens that goes down into those low powers and have a little more customization if somebody really wants a fine refractive endpoint. But I would say the majority of them were doing a basic monofocal 3-piece implant.
All right, I think this is the last one. This is a 53-year-old patient, came in for a new refractive eval. He had LASIK previously, 2008, in Denver, hyperopic LASIK. He was currently using Restasis. He had dry eye, typically wore soft lenses, tried sclerals in the past, but didn't like the comfort, had a hard time with the soft lenses because of his dryness. Uses cheaters when he has his contacts in. His uncorrected vision, 2100 in the right eye, 2060 in the left. He is super hyperopic with a decent amount of sil. He had, as I mentioned earlier, difficulty with the contacts, and he didn't totally know his history. He didn't know if he was amblyopic. I think we found out from the referring doctor that he was. He had, so that's his pentacam on, is that your right? On the right, and then the biometry measurements on the left. And because of that hyperopic LASIK treatment, those did not match real well. And ideally, for this guy, well, I won't give it away, but ideally those would match much better, and his did not. So this one's gonna go to Miss Peacock. So with variability in the Ks, I'll go to the poll. Would you do a hyperopic ICL? Would you lift the LASIK flap and enhance him? Do nothing, continue in contacts, or an RLE?
Well, we can't do a hyperopic ICL, so that's
Correct.
Flap lift with LASIK enhancement, not going to do a +7. I would have liked to have seen a gas permeable over-refraction to know if it's aberration induced on that right eye, to see can I get him better than 20/50 or whatever, 20/70, whatever it was. I'd like to know what his best corrected opportunity is. And he has a clear lens otherwise, right? So 20/50 in that right eye.
Yeah.
I would have maybe thrown a GP on just to see if I could get a better
We did
vision.
confirm with his doctor that he was amblyopic.
Okay, so he's definitely 20/50 in that eye.
Yeah.
I think looking at this patient, he's 53, he needs an ad power all the time, he's got a super hyperopic refractive error. I probably wouldn't touch the cornea anymore, so I would be looking at RLE or bust for him.
Yeah.
And go forward with that and talk about different options. I'd like to see, some sort of aberrometry type of measurements just to see his vision quality, but, we'd talk about all the options and go forward with, whatever his goals were from a glasses independent standpoint.
Yeah. So the next slide is what IOL would you choose? I agree, RLE is really his only option to get him less dependent. This one's for Professor Plum. What IOL would you choose for this?
That is not a good multifocal candidate. A monofocal toric, there's a little bit of irregularity. there's probably enough irregularity that an EDOF would even be maybe a little hard. So probably my first choice with this, if they dilated well enough, would be to do an adjustable lens, because you have such an opportunity for refractive surprise with this LAL, or with his hyperopic LASIK. You don't really want to be doing a laser enhancement on that cornea, and so having the adjustability factor to give us the best chance of hitting it. Again, ideally, getting a little more consistency in his Ks even to be able to pre-pick that, but that would be my recommendation.
Yeah. That was your recommendation, because I talked with you about him, but, I think.
One thing to bring up would be, I would go back to the pentacam. If I saw this in practice, I would maybe have them repeat the pentacam to make sure that the pupil is really centered. That's and probably the Argos as well. I'd have them repeat both measurements to make sure that especially on like a amblyopic eye, they could be slightly drifting, or maybe even like a microtrope where they're not totally lined up, and then that's gonna throw off your Ks because, you're not getting the apical center of the cornea.
So he has not had surgery yet. He was planning to schedule out a ways, just because of his schedule and a little bit because of our schedule. So we will bring him back for repeat scans. And this is just a shout out to my friends that traveled a long ways to come to education today. Jenny and Brittany are here from Grand Forks, North Dakota, and Salt Lake City. So that's just our kind of evolution of our friendship over the years from optometry school till now. And the most recent picture on the bottom is a concert we were at a month or so ago. And then last poll, I know we're out of time, is Professor Plum, not Dr. Swan, Professor Plum, a Cats or a Grizz fan? And you get a little hint. So go ahead, vote. Whoops, hang on.
Oh, that's too bad. It just went to the Cope
shoot.
credit. That's a bummer. The only guy.
I mean, you did dress in maroon today.
Sometimes you lose bets, and it's a really sad thing when that happens.
We do have a couple of questions we can jump into quick before I start mine. One was at the very end of the cataract conversation. What are you guys' thoughts on what percentage of cataract patients need to have a YAG post-surgery? And I would say
Most.
at any point in time.
Yeah, almost all at any point in time.
I tell patients 60 to 70% of patients will likely need a YAG.
I usually say at least 50.
I
Okay.
say 70, I think. Yeah. But I say it could happen months to years after cataract surgery, so they're not surprised. Sometimes they'll say, oh, but I had cataract surgery 5 years ago. Yeah, it can happen.
Another question, does the Billings office have endothelial cell count ability?
No.
Okay. What are your thoughts when we talk about ICLs? Knowing that, one of the points of, not necessarily emphasis, but one of the things is making sure that they've got a good, healthy endothelial cell count, as far as not being able to measure it versus making it a priority prior to.
Yeah, I mean, I would say there's quite a bit of variability out in the United States of like ICL surgeons, whether they get preoperative endothelial cell counts. In general, a visual assessment of their cornea, looking at their corneal thickness, gives us a good idea if we're going to need it. And so I feel very comfortable proceeding with ICLs without endothelial cell counts, and I would say the majority of surgeons in the US have moved to that. In the early stages of ICLs, it was definitely more common that people would get it on everyone. With the fenestrated ICL also, it's just a lot more forgiving lens, less likely to have an IOP spike early on that could cause issues to the endothelium as well. So I feel comfortable without it.
Yeah, I think I would add that these ICL candidates, typically younger patients, right? 20, 25, 30, 35 years old. Like, it's pretty apparent if there was an endothelial issue at that age. Like, for most times, it's not a deep concern from that perspective.
Yeah, I would say that in the ICL space of things, usually the ECC is not the reason that they can't have surgery. So it's pretty rare that the ECC is the limiting factor.
Another question, any issues with standard dilations after using or after having a patient that's been had a piggyback lens placed? So post-operative, they're going in for their routine exams. Is it okay to dilate if you know that patient's already had a piggyback?
Yep, totally fine to dilate until we get to a later lecture when maybe it's not in a certain case. But yes, I tell patients if they have a piggyback ICL, it's totally fine to have routine dilation, no problem.
Plot twist.
Dun, dun, dun.
And then last question, Ceara, what's your opinion on SMILE refractive surgery?
We don't offer it here. I haven't worked with a surgeon that's done SMILE a lot. I think there's a place for it. But it's just, there's so many other options that I think it's pretty rare that would be their only good option.
Yeah, and I think the other thing on that is just, if you look at their visual experience for afterwards, it's not quite as slow healing as PRK, but it's also not as fast healing as LASIK. And early on, there wasn't great astigmatic corrections. There's also not wavefront optimized or topo-guided treatments. So the enemy of SMILE, in my opinion, is that our outcomes with wavefront optimized and topo-guided LASIK are so fantastic with PRK. So there's not an incremental benefit that I see.
That's it.
All right, thank you.